Welcome to ACEs Are Not Destiny, a pre-work webinar for your trauma-informed care community of practice. Next slide. In today's webinar, we will be discussing an overview of trauma, its impact, and its prevalence, as well as the connection between trauma and addictions. Next slide. The learning objectives for today are that participants by the end of this session will be able to define trauma, describe its impact, and understand the correlation between trauma and long-term health and social outcomes. My name is Dr. Linda Henderson Smith, and I am the Director of Children and Trauma-Informed Services at the National Council for Behavioral Health. I am also faculty in your community of practice, so we will have an opportunity to meet and talk as we proceed. So before we get started, we wanted to make sure that we gave you some questions to really be thinking about as we go through this webinar. What we'd like you to be thinking about is, how has trauma affected our clients, participants, or patients, our staff, and our community? Throughout this webinar, I'll be using words like clients, participants, and patients interchangeably. So let's go ahead and let's get started. According to the Substance Abuse and Mental Health Services Administration, trauma has three key components. It's an event or set of circumstances that is experienced directly or indirectly as overwhelming or life-changing, that has profound effects on said individual's well-being, psychological development, or has physiological, social, and/or spiritual impact. Events and circumstances may include the actual or extreme threat of physical or psychological harm or severe life-threatening neglect as well. It's important to recognize that the individual's experience of these events is very much so their experience. And so we have to be conscious and careful of indicating when we don't believe something is traumatic for someone. Examples of trauma include child maltreatment and complex trauma, medical traumas, serious accident or illness, natural disaster, war, terrorism, and political violence, victim and witness to domestic, community, and/or school violence, actually being and experiencing traumatic grief and separation or significant loss, and historical and intergenerational trauma. Next slide. One type of trauma that is often overlooked is that of intergenerational or historical trauma. Intergenerational or historical trauma is a multi-generational traumatic experienced by a specific cultural group or collective community. According to Yellow Horse Braveheart, it is a collective, cumulative, emotional wounding across generations resulting from a cataclysmic event. With these types of traumatic events, the trauma is held personally and passed on across generations. Even those who did not personally experience the trauma are affected generations later. So what are some examples of intergenerational or historical trauma? Next slide, please. Well, here's a list of them. Genocide, slavery, pandemics, massacres, prohibition or destruction of cultural practices, discrimination or systemic prejudices, and forced relocations. Next slide. Now, we all know that intergenerational and historical trauma has some negative effects that really we can see now through things like behavioral health disparities, right? Things like depression and anxiety, isolation, loss of sleep, anger, discomfort being around Caucasian people, shame, fear and distrust, a loss of concentration, substance abuse, and violence and suicide. On the other side of that, however, there have been some additional positive effects that have come out of those situations as well. That include resilience, right? Which is the ability to become strong, healthy, or successful again after something bad happens. The adaptive survival behaviors like increased religious or spiritual coping, and evolutionary enhancements as well that like the strong survive. It's important to understand that though intergenerational and historical trauma have long-lasting negative effects, through those types of events, these positive effects also have come up. Next slide, please. So what does trauma do? Trauma has an impact on individuals, on communities, um, and on larger cultural groups. In any of those situations, trauma has a habit of shaping our beliefs. It shapes the way we look at the world and creates a situation where people feel like the world is not a safe place. The people within the world are not a safe place. It is not a place where they would be able to seek solace or get assistance. It also tends to impact people's spirituality and polarizes them either all the way towards a spiritual relationship or all the way against a spiritual relationship. Oftentimes, when we work with individuals that have that polarized view of spirituality, it comes from a place of having experienced trauma. And lastly, trauma has a tendency to really shape the way in which we view ourselves and change our own identity. Traumatic situations can make people feel unseen, unheard, unlovable, unworthy of connection, like they have absolutely no control over what's happening to them. And that possibly for some people that they are a victim. And so it shows up oftentimes, all three of these show up in their behavior later. Next slide, please. The other thing that trauma has a tendency to do is impact our body. Our body has a natural reaction to trauma called our fight or flight response. It's also called the survival mode. When our survival mode is actually kicked in, we have a physiological response that really truly helps us in times of stress and trauma. Our heart beats faster, our blood pressure increases, our adrenaline and cortisol, which are the stress hormones, surge through our systems to make us stronger, faster, more alert, and more powerful versions of our normal selves. In short, these psychological changes that come with stress and trauma also give us the physical resources to deal with whatever may break us at that moment. But it's only designed to actually happen for brief periods of time. When someone has experienced high levels of trauma and this physiological response is activated on a regular basis, it actually causes quite a big problem on our body. The stress becomes toxic and can cause dramatic changes in the brain and the body. And it causes us to be harder to heal from those situations. Next slide. Additionally, it's important to understand that as part of this physiological response and our brain and our body's response to trauma, we actually remember both external and internal reminders of that traumatic event. When a traumatic situation happens, we remember and code the smell, the sound, the sight, the touch, the taste, the emotions, and the thoughts that actually were happening at that moment of the traumatic event. And later, what can happen is that if we smell, hear, see, touch, or taste any of those things, or if we actually have those same emotions or those same thoughts, our body can automatically be triggered back into the physiological response of fight, flight, or freeze. Now, one thing to keep in mind about this is that oftentimes the smell, the sight, the sound, the touch, the taste, the emotions, and the thoughts are not in our conscious brain, but really truly in our fight, flight, or freeze response. So we don't necessarily know what those smells, those sounds, those sights, those touches, those tastes, those emotions, and those thoughts really are until we're triggered by them again. So oftentimes, next slide, what's sitting in the room um, from seen and unseen burdens that people are bringing into the room with us, and this is whether it's our clients, our participants, our patients, our staff, right? What we normally see sitting in the room based on trauma are all of these things: anger, defiance, disrupted mood, regressive behavior, perfectionism, fear, traumatic grief, shame, low self esteem, dissociation, inattention, mistrust, difficulty forming relationships, physical illness, lots of guilt and persistent irritability, aggression, a need to control. Sometimes we also see things like avoidant behavior, depression, and hyperarousal. So, not suggesting that if you see these things, someone has actually must have experienced trauma, but understanding that there is a high correlation between these responses and having a traumatic past or traumatic history. So let's talk, next slide, a little bit about the trauma um, and the human stress response. Next slide. As I indicated earlier, when a traumatic event happens, we innately either fight, flight, or freeze. All of the above reactions are normal, and depending on the traumatic situation that happens, will determine how our body naturally wants to protect us and takes over, if it's the fight, the flight, or the freeze. Now, what's important to understand about this is that it often happens when we are in a state of fear or terror, right, from stress or from trauma, and that our brain is unable at that moment to really truly respond, process, or learn when we are in a state of fight, flight, or freeze. Next slide, please. So, according to Dr. Bruce Perry, depending on where in the brain is regulating your system, it will determine how you then respond. The brain is the central stress organizer and the interpreter of what is stressful. What we know is that particular neurons in the downstairs of the brain, or the brainstem, are connected to particular neurons in the upstairs of the brain, which is the cortex. These particular neural networks are the wiring for our stress response. If these neural networks are optimized, we see full human potential. If these are altered, causing dysregulation, we see a cascade of problems in all parts of the brain. The human brain is very plastic, and because of this neuroplasticity, brain development continues throughout the lifespan, meaning we can retrain the brain even as adults, but not all parts of the brain are as easily changed as others. Now, what we know additionally about the brain, next slide, is that the amygdala, which is your brain's threat detention center, can become overreactive, engaging in a constant program of looking for, seeing, and assessing threat. This can cause us to feel intensely anxious, vulnerable, and fearful. The hippocampus, which is your brain's center for processing memories, can become underactive when trauma actually happens. Rather than consolidating and then placing memories in the outer layer of the brain for long-term storage, memories can get hung up in a present-day loop. And the result is that people experience and re-experience intrusive, disturbing, and uncomfortable recollections. The cortex, which is your brain center for effective control, becomes interrupted by survival-oriented instincts from deep inside your inner brain. These instincts overrule logical thinking, diminish cognitive processing, and decrease a person's ability to inhibit behavior. Even when you try to refrain from things like addictive behavior, for example, you can experience an unstoppable urge to engage it. When we see and have lots of experiences with trauma, it doesn't just, happen in that one situation. Really, truly, it can change the way in which our brains are constructed. In a typical development, very little of our brain space and brain time is spent in survival, and most of it, right, is spent in a place of cognition, a place of learning, a place of abstract thinking, reflection, processing, and responding. But when people have experienced a lot of developmental trauma or have experienced a lot of trauma throughout their life, what we've seen is that actually the complete opposite happens. A lot of their time, a lot of their brain power is spent on trying to make sure that they're surviving, which leaves little space for the processing, responding, and learning. For example, a child in a classroom who has experienced lots of developmental trauma doesn't necessarily know, when they're going to be able to eat next, if the lights are going to be on, if their parent, is going to be home or not. They are sitting in class, most likely thinking about and processing what they're going to eat, if they're going to be safe when they get home, how they can make sure that they're safe and get what they need when they get home. They're going to be focused on their survival, not necessarily listening well to the teacher in the classroom that's trying to teach them how to add and subtract or how to read and things of that nature. So we need to understand that when we're working with children and families, or even working with adults, because children become adults, we also need to be very cognizant of the fact that the way in which their brain processes and what it is that their brain is focused on at the moment might be different than what we would quote unquote normally expect. Next slide, please. So I said all of that to really kind of discuss what Dr. Bruce Perry says is the arousal continuum. What he says is that your brain function is state dependent. So our level of arousal is dependent on our internal state. When we are calm, we can think abstractly. If we are on the dissociative or arousal continuum, we are at rest and we can think about our extended future. If, for example, we are at a place of alert, our cognitive style is much more concrete. We have a tendency, if we're on the dissociative continuum, to be avoidant, or if we're on the arousal continuum, to be vigilant. And in that place, when that's where our brain is, we can only think through days or hours. Most people, for example, when they're at work, are generally in a state of alert, at least. And so you have some individuals who will create a to-do list and will check it off very vigilantly throughout the week of all the things they need to do. Other people will not necessarily do that and kind of avoid and just deal with what comes up throughout the day. Even when we're doing those checklists or thinking through, just coming up with what's going on throughout the day, we're only doing that for the next few hours or days. We're not necessarily writing a checklist or a to-do list for the whole year. Now, when someone is in a state of alarm, their cognitive style is much more emotional. If they're on the dissociative continuum, you might see things like compliance or robotics. If they're on the arousal continuum, you would see things much more like resistance or crying. And in that moment, they're only really able to think through things from hours to minutes. I like to use the example of a toddler who's quiet in the other room doing something, and a parent yells their name, tells them to stop, and one of two things generally happens. Either you have them stop and come and say, okay, I'm sorry, or you have them crying and resistant and saying, but I didn't do anything. What did I do? Right? And in that moment, depending on how we engage with them, we need to understand that their brain only can function and respond to the next few hours. So if we say something like, well, if you don't stop, I'm not going to take you to the park tomorrow, you're going to see the behavior continue again. However, if, for example, you say, if you don't stop, you're not going to get dessert after dinner, and you happen to be cooking dinner at that moment, you might see a change in behavior. Now, if someone is at a place of fear, their cognitive style is much more reactive, and this is really truly where the fight, flight, or freeze begins to kick in. In this situation, if you're on the dissociative continuum, you would see dissociation and fetal rocking. If someone's on the arousal continuum, you would see defiance and tantrums. In that moment, they can only process, learn, or respond in the next few minutes and seconds. And lastly, if somebody is in a state of terror, where their cognitive style is reflexive, you might see things like fainting if someone's on the dissociative continuum, or aggression if they're on the arousal continuum. And in that moment, they have no sense of time. Now, why is this important? This is important for when we're engaging with our clients, patients, or participants and really thinking about where they are and how we respond in that crisis or in that moment where they may be escalated or triggered into fear or terror. But it's also very important for us to understand where we are on this arousal continuum in that same moment. If they are at a state of terror and we are at a state of fear, really thinking about if we're the best people to intervene or if someone else might be a better person to come in and try to calm down that client or patient or participant moving forward while we take the time to also do that. Next slide, please. Ultimately, what's important to continue to understand is that when someone is in the survival mode response, they are unable to respond, learn, and process. So this is not the time to attempt to solve issues. This is not the time to really attempt to teach someone new coping mechanisms or to try to process why they're behaving that way. What we need to learn how to do is really calm them down and really look at and think about how we can get them to a calming place, and what interventions we can do to do that. And so what Dr. Bruce Perry says, next slide please, is that any intervention that we put in place in order to calm the brain and move people from the right to the left on that chart needs to have what we call the 6 R's. It needs to be rhythmic, it needs to be repetitive, it needs to be relational, it needs to be culturally relevant, it needs to be rewarding, and it needs to be culturally respectful. So examples of things include, walking, listening to music, in several facilities across the country, they're starting to use things like animals to help calm people down. So animal assisted interventions or music and drumming as a way to kind of keep people calm or to calm their brains before when they're starting to escalate. So I want to transition now to really kind of the trauma prevalence and research perspective. So let's talk first, next slide, about the Adverse Childhood Experiences Study. In the mid-1990s, the Center for Disease Control and Prevention and Kaiser Permanente partnered to do a study. They screened over 17,000 adults, mostly middle class, college educated, employed Caucasians, for these 10 adverse childhood experiences that are also called ACEs before the age of 18. They were looking to see if there was a correlation between these childhood experiences and the negative health outcomes that they were seeing in their populations. The researchers found that almost 67% of the individuals screened had experienced at least one ACE, and over 20% had experienced 3 or more ACEs before the age of 18. Now, the ACEs include child physical abuse, child sexual abuse, child emotional abuse, physical neglect, emotional neglect, mentally ill, depressed, or suicidal person in the home, drug addicted or alcoholic family member, witnessing domestic violence against the mother, a loss of a parent to death or abandonment, including abandonment by divorce, and incarceration of any family member. And what they asked them to do was simply to say yes or no if they had experienced those things between the age of 0 and 18. And they also then did this correlation study with the health outcomes of those individuals. Next slide. Now, what the ACE study found is that there's a dose-response relationship between the ACE score and many health outcomes across the lifespan, including smoking, obesity, and heart disease. Examples, right? If somebody has had 3 or more ACEs, they are 4.6 times more likely to be depressed, 4.7 times more likely to use illegal drugs, 7.4 times more likely to become an alcoholic in adulthood, 10.3 times more likely to use injected drugs, 12.2 times more likely to attempt suicide, right? A lot of these things, 1.6 times more likely to be severely obese and or have diabetes. So what it found basically was that early experiences of childhood negative adverse experiences really impacted adulthood for individuals if they had not necessarily gotten assistance along the way. Now, I do want to point out that one of the additional things that this found also was that those with 3 or more ACEs actually were also seen to die 25 to 35 years earlier than the general population. So this study, along with many others that we're going to discuss, really kind of was the groundbreaking foundational study. 38 states have implemented the same study across the country and have found similar results, if not worse. So at least 67% of individuals had experienced one of those 10 things before the age of 18, and around 20% or more had experienced 3 or more. Now, again, those 10 things are not the only things that would be considered adverse childhood experiences. And so several studies have actually additionally looked at discrimination, poverty, homelessness, in an urban study in Philadelphia to see if additional adverse childhood experiences changed the data, and it still came out to this being at least the minimum. So another study that was done by Randall, O'Malley, and Dowd in 2015 also found that there's this huge correlation between the parent's adverse childhood experiences score and the child's adverse childhood experience score. And so this is also important for you all when thinking about how you work with your patients and your clients and your participants, and what the impact that the work that you do has on future generations as well. So children of parents with ACE scores of 4 or more are 6.3 times more likely to experience household substance abuse, 10.4 times more likely to experience homelessness, 12.7 times more likely to experience neglect, and 44 times more likely to be exposed to intimate partner violence. So all of the research and studies that have been done continue to show that one family member's experiences of trauma can really impact generations to come. Next slide. Another study that was done by Dr. Chris Blodgett, who directs the Washington State University's Area Health Education Center. What he wanted to do was answer 2 questions. How common are ACEs in school children, and how does childhood adversity affect a kid's academic performance? He looked at the records of 2,100 randomly selected children. The records were set up so that the children could not be identified, and administrators provided another set of eyes on the data. And in this group of 5 to 12-year-olds, 78% were white, 55% were eligible for free and reduced lunch, which are all a poverty indicator. And basically, based on what he found, what he actually indicated was that 45% of the students had experienced one or more of these 10 severe and chronic types of adversity, 12 had 3 or more, and just like the CDC's ACE study, the more types of adverse experiences a child had, the more their academics suffered. He found that the level of ACE exposure was the principal predictor of a child's attendance and behavior problems. Even figuring in other factors, ACE exposure was the second most powerful predictor of a child's academic failure. The first, if the child was in special education classes. So compared to children that had no adverse childhood experiences, what he found was that kids with 3 or more ACEs were 3 times more likely to fail, 5 times more likely to have severe attendance problems, 6 times more likely to have severe behavioral problems, and 4 times more likely to have self-reports of poor health. Additionally, SAMHSA, the Substance Abuse and Mental Health Services Administration, released a developmental trauma issue brief in 2017 and indicated that children with 2 or more ACEs by the age of 8 are 3 times more likely to repeat a grade and 2 times more likely to have a special health care need. So the exposure to trauma, especially in early childhood, can truly impact a person's trajectory towards fulfilling their full potential. So lastly, let's transition to trauma and addictions and really look at this correlation. Next slide, please. Individuals who are already abusing substances may be less able to cope with the traumatic event as a result of the functional impairments associated with the problematic use. To more fully explore this link between trauma and addictions, it's going to be helpful for us to first develop a working definition on what constitutes addiction and trauma. So let's talk about Gabor Mate's definition of addiction. According to Dr. Gabor Mate, an addiction is any behavior that's associated with craving and temporary relief with long-term negative consequences that a person is unable to give up. This can mean substances, this can mean gambling, this can be food, this can be exercise, this can be work, right? All of these things can be considered addictions if they meet these two criteria. Today, we're going to focus more on the substance use definition of addiction, but I wanted us to make sure that we understood that addiction is not just about drugs and alcohol, but really truly about any behavior that's associated with this. And what Dr. Gabor Mate says is that early emotional loss and or trauma is the template for all addictions, no matter whether it's drugs, alcohol, or any of the other things that I mentioned. So some version of this statement, the next slide please, is unfortunately a heartbreakingly common thought often expressed by someone coping with addiction. It is also heartbreakingly common among those who have unresolved trauma. Research continues to show that both trauma and addiction create an internal war fueling physical, psychological, emotional, and spiritual chaos. When trauma and addiction intersect, a person becomes entangled in a self-perpetuating cycle that must be fully and holistically addressed in order to allow healing from such pain and discord. Now, what are some potential reasons for addictions? I'm going to go through a few of these, but also think about what are some other reasons that you may consider. So the first is that people really truly utilize addictions to stay safe. Trauma can feel like a danger zone, which makes being out of it feel safer than being in it. Another reason is that people use addictions to escape memories because unwanted and unresolved memories have a way of popping up incessantly after trauma. And addictions offer the mind a different area of or reduced capacity to focus that helps suppress reminiscing. The third reason is to soothe pain because substances or the adrenaline rush of the self-destructive behaviors change our body chemistry, releasing endorphins and other mood enhancers that reduce discomfort. Another one is to be in control. Sometimes engaging in addictive behaviors can lead to feeling strong, resilient, and courageous. Experiences that are tremendously alluring when trauma from the past intrudes on the present. And again, if you remember, one of the things I stated earlier is that trauma has a tendency to change the way people view themselves and their own identity. And one of the ways that it changes them is that it creates a feeling of being out of control. If I feel like I am out of control, I can potentially use a substance, right? Because that's one thing I can control. I can control what I put in my mouth or my arm. I can control how much I do. And so people tend to use addiction sometimes to really kind of make them feel as if they have control again over their lives, which is oftentimes when we hear things like, I can stop at any time. Another reason is to create a tolerable world. And that's about the intense feelings brought on by fear, memories, and anxiety can really make any moment seem overwhelming. And so the release of tension brought on by addiction-oriented behavior helps facilitate a manageable experience. The next one is to create alignment. Trauma can really leave you feeling less than, worthless, hopeless, and damaged. And the more self-destructive one behaves, the more it can feel like he or she is living in alignment with who they truly are. While this may be false, it can help reduce feelings of otherness and disconnection. And then lastly is to redefine oneself. Engaging in addictions can help create a sense of community by connecting to others who feel, see, think, and behave the same way. Or addictions can help by allowing one to engage in or act out behaviors that allow one to feel stronger, more courageous, and capable. These are just a few of the actual reasons, but I think it's important for us to understand that for all addictions, there's not just one reason. Ultimately, trauma tends to result in a vicious loop. When coping with trauma and or addictions without the necessary coping and resilience skills, coping negatively by utilizing addictions, right, can really put people in vulnerable positions, but can also lead to additional traumatic events. It's important for us to understand, however, that all it really takes is one healthy relationship for people to get off of this roller coaster. One relationship with someone that is trusted, that is hopeful, that holds people accountable, and that is there unconditionally to really support them through, even if they make mistakes, can really make the change necessary to get people off of the trajectory towards early death and onto the trajectory towards healing. One thing I hope that you really truly take away from today is that healing happens in relationships. And so it's going to be super important for us to be focusing on how we build those relationships to help people get off of that vicious loop. Next slide, please. Terrence Real says, an addict needs shame like a man dying of thirst needs salt water. And according to Brene Brown, shame is the intensely painful feeling or experience of believing that we are flawed and therefore unworthy of love and belonging. That something we've experienced, done, or failed to do makes us unworthy of connection. Unfortunately, for those who have experienced both trauma and addictions, it is often that they feel these feelings of shame. And so we've got to really truly focus on how we can not have people feel that shame, have them feel reconnected, have them feel as if they are worthy and loved and they belong, and that they're worthy of connection as well. So let's discuss how we can potentially do that and assist. So one way we can do that is through medications, right? There is medication-assisted treatment that has been proven to really be a, helpful as it relates to addictions. Now, one thing about those medications is that what has been proven is that it's not just the medication, but the medication assisting the treatment. So ensuring that people are not just getting the medication, but also getting the treatment that they need to help them process the underlying trauma is really something that we can do to help. Another thing that we can do is really referring people and connecting people with recovery coaches or using technology to really kind of help people track where they are, how they're feeling, and staying connected to the people that can help them. But these last three are really three that anybody can do no matter where they are in working with clients, participants, and patients. And that's prioritizing the relationship, learning who that person is, how that person really receives appreciation and connection, and prioritizing building the relationship so that they do begin to trust again, they do begin to engage again, and they begin to communicate when things may be not where they should be with them. Another is to seek ways to build connection, not just individually, but back with the community, where they can really understand that they are a part of the community, and that the community accepts them and is there to support them. And then, of course, embrace compassion instead of punishment. Punishing actually tends to drive more the message of you're unworthy of connection, you're unloved, and you're not necessarily who we want you to be. So what we need to be doing is really recognizing everyone's humanity, right? We're all out here trying to survive. And what we often see in terms of behavior with our clients, our patients, our participants, our coworkers, and each other, right, are misplaced coping strategies. And since we're all part of the problem, we can really truly be all part of the solution. So the key takeaways from today are that trauma is a universal human experience. It's not just for the clients that we serve, it's also for the people that are serving next to us, our friends, our families, our community members. It's something that oftentimes is experienced by a lot of people. Trauma impacts not just that one person, but it impacts their behavior, their triggers, their body, and their long-term health outcomes. And then the last one is that trauma is truly subjective, meaning each person's experience is defined by them. We don't have the right to tell them about their experience being not traumatic. We need to engage with them and support them through what their experience of trauma has been. So as you go away from this webinar, again, I hope you really start to think about how has trauma affected your clients, your participants, and your patients? How has trauma affected your staff? And how has it really impacted your community? We have some resources for you all if you would like to watch them or click on them. And again, I just want to thank you for participating in today's webinar. If you have any questions, please feel free to give us a call or to send us an email or visit the temporary website that you currently see here. This webinar was produced for the U.S. Department of Health and Human Services, Health Resources and Services Administration under contract number 75R60219C00002. I thank you, and I will talk to you soon.